Welcome to Heart Nurses, brought to you by the Preventive Cardiovascular Nurses Association. PCNA's mission is to promote nurses as leaders in cardiovascular disease prevention and management.
On today's Heart to Heart podcast episode, we are excited to be partnering with Medical Alley to bring you the second part of this 3-part mini-series on health equity. If you like what you hear, follow Medical Alley Podcast or visit medicalalleypodcast.org.
Good morning, good afternoon, and good evening to everyone out there in Medical Alley. Thank you for joining us on another episode of the Medical Alley podcast. This is your host, Frank Jastalki, and we're having another one of our fantastic conversations as part of our partnership with the Association of Black Cardiologists and the Preventive Cardiovascular Nurses Association. This time on one of the most important topics, healthcare workforce and the topic of burnout and strain. I'm so pleased to be joined today by two fantastic guests who are going to share their perspective on the issue and some of the things we might do as a community and as an industry to better address these issues. Joining me today is Nikki Akparewa, who's a nurse entrepreneur, and Dr. Michelle Johnson, who's the Vice Chair of Health Equity and a Clinical Director of Cardiology at Memorial Sloan Kettering Cancer Center. Thank you both for joining me today. Nikki, I might start with you, and Dr. Johnson, I'd appreciate your perspective as well. When we say burnout, what do we mean, and how does it show up in the healthcare professions and contribute to turnover and other challenges?
Yes, I think that's an excellent question. And again, just thank you so much for having me on the show today. My name is Nikki, and I am a nurse. I've been a nurse for almost 20 years. And so when I think of burnout, I think of it as very personal, right? Not so much a scripted definition, but for me, personally, burnout have been those experiences in which I have felt that I've given all that I could to the role, and I did not feel that it was making me feel fulfilled as a nurse practicing, whether bedside or in community or, working with as a case manager, where you're giving more than what you're getting back. And burnout is endemic, unfortunately, in nursing, almost specifically, where we know that nursing, we experience lots of instability, right? So nurses are really getting to a point now where burnout is not only on the rise, but it's really taken front seat as COVID has really amplified the impact of burnout for so many nurses. And what nurses have been saying and have been trying to say for many years is that burnout makes them feel unsafe, right, to practice. It also happens in a way where they feel lack of validation and support from their management and peers. And that's also coming from a lack of flexibility, where these schedules that they have are really difficult, or they may be required to stay over their shift when they work 12 hours, right? So this is where you're starting to see persons who are experiencing burnout when they feel like that they have given everything that they can and they still don't feel validated, safe, or have the capacity to care for themselves or their family in the way that they really need to.
Oh, indeed. And thank you for sharing that. It's personal and individual, not just some rote definition we might give. And Dr. Johnson, what about from your perspective?
Well, thanks again to our host and to Nikki for sharing in what I think is a very timely and very important conversation. From the physician side, clinician side, we using a more technical definition, I guess, which includes some of what we just heard. Burnout is the syndrome which includes the emotional exhaustion that we highlighted in our first answer. It includes a loss of interest in work, feeling ineffective, or having a sense of reduced personal accomplishment, which you just heard Nikki describe. And there is also an element of depersonalization that can go along with burnout, a tendency to see people as objects rather than as humans. And you can imagine that any and all of these things could have negative impact on patient care. So, really an important issue, far higher rates in our physician colleagues or physician body post-COVID than pre-COVID, but continuing, even though the pandemic's over, the rates of burnout in the physician community remain high.
Right. And I want to dig more into that part of it, but where I might start in this, first part of the discussion, if we go back to the clinical training, the education that doctors, that nurses, that other healthcare professionals are getting, are there things we could or should be doing at that level to better prepare healthcare professionals or to better manage the situation? I don't want to minimize it, but maybe starting from that point, are there things we should be doing?
So one thing I can say, and that I think this is a really timely and important question, is that what I experienced, at least for me, and I went to nursing school almost 20 years ago, right? It wasn't talked about at all. Burnout was not discussed in my education. It wasn't discussed while I was trying to prepare and while I was training for the work that I was going to go into. So I think for me, I experienced a really steep learning curve, and I was really shocked to really have these experiences my very first year at the bedside that I just almost felt like I was going to leave the profession. I really felt a lot of incivility, which is those feelings or those behaviors that are considered demeaning, rude, and demoralizing. Mm-hmm. I had experiences where I saw other people that were not being treated the same way that I was being treated. And we can talk about that a little bit more later, being a nurse of color as well and what that looks like. Mm-hmm. But for sure, burnout is not really effectively addressed in nursing education. And to that end, one thing that I have really done and really worked really hard as a nurse to model for my students, because I'm a clinical instructor as well, mm-hmm. is to give them just to help them understand that this is the work that they're going to be going into, that it's difficult, it's challenging, and to prepare yourself, right? So you're mm-hmm. not walking into it just completely thinking that I'm here because I care. I'm here because I, want to take care of people. All of that is great. And that is very necessary and important. And we really need that. And we want them to know that persons who are working at the bedside, many of them are just intentionally decreasing their work effort because they're so exhausted. And, we have nurses that are saying, listen, our seasoned nurses who have been there for years, 71% of nurses that have over 15 years of experience are leaving the profession, wow. As soon as possible. So when you have persons who are leaving the profession who are seasoned, and you have lots of newer people coming in who really don't know this work, burnout is really, really common. So one thing that I do is really talk to my students about what burnout is mm-hmm. and how to prepare themselves and how to safeguard and when to walk away and how to advocate. I think all of that is really necessary, but I don't think they're getting it from every faculty member or clinical person. And so I think that's something that we need to do better at as clinicians.
That seems to be true in so many facets of life, that while it is not the be all end all, it is often a starting point of acknowledging and talking about the reality of a situation and the problems that are out there. Dr. Johnson, what about from the physician side in education and training?
So I agree with what's been said. I would highlight too that it is a shared responsibility. And while we, of course, want to look at strategies and behaviors and techniques that we can equip our young trainees with, that this is a responsibility also of institutions and training programs right. and the medical profession as a whole. The burden and responsibility doesn't lie solely on the trainees. So to echo what's been said before, there's a paucity really of information. We don't have a lot of evidence-based approaches to understand techniques and how to mitigate burnout. And as has been said before, including these strategies or what is known in training programs is relatively new. Techniques are putting in place programs that will ensure med student well-being is important, making sure that there are adequate services for students who identify as being burnout or in distress. optimizing learning environment, looking at the curriculum, grading, how the day is structured, all of those types of things, providing support, making students feel a sense of belonging, not feeling isolated. All these things help to mitigate burnout. And there's certainly space for more of this to be done in medical education across the board.
Yeah, and you started going this direction a little bit at your mention of the institutional responsibility as well. What about on the management side, like setting aside the educational piece? You've both illuminated a handful of the challenges that exist in healthcare at the bedside today. Dr. Johnson, I might ask you to start, and then Nikki, following with you. What about the management or the administrative side? Are there things that healthcare organizations can do, should do, are doing to create a better environment where the burnout is reduced, or where it's better managed if it can't be reduced?
So I think there's certainly opportunity to decrease burnout. And I would highlight that physicians are known to have high levels of individual resilience. So the techniques to decrease burnout are not going to be effective if all we look at is individual resilience on the part of our clinician workforce. So I'll give you some examples of things that cause burnout. We've already mentioned incivility, and institutions can set the tone for what behaviors will and will not be accepted in their clinical environment. We know that having the electronic health record transitions to bureaucratic tasks, all of these things add to burnout. And making sure that we are asking our clinicians to be efficient and providing them with best tools to do so. Support staff, manageable work schedules we've already talked about, making sure that people feel respected both from their peers and from the patients who they treat. All of those things are institutional mandates that can have positive impact on efforts to mitigate burnout.
Indeed. And Nikki, I'd ask for your perspective as well. And you mentioned a couple of minutes ago that there can be also different challenges for nurses, clinicians, providers of color. Could you maybe expand upon that as well?
Yeah, sure. So one example that I'll share with you that really stuck out to me when I was going through my training initially was I remember having a peer, a colleague of mine, another nurse of color that started with me, and she was in her orientation. She left a bed up a little bit too high while she was trying to learn how to do her job, right? This is within the first couple of months, and they pulled her into the office, told her they wanted to extend her orientation, offered to send her to another unit to work somewhere else. Okay. She did not feel, comfortable with the approach that they took to that process. Meanwhile, a white nurse who walked out of a patient's room, told the patient to do their own HIPAA cleanse. Patient takes all of their monitoring devices off. We didn't even realize, that the patient was off the monitor. Oof. Someone comes in the room, finds this patient has actually passed away. And this nurse was cross-trained to our ICU, which is a coveted thing, right? So when I saw this kind of interaction happen, and some things happened to me as well, but that was stark for me to watch how one nurse of color left a bed up and was told, hey, you can go somewhere else to work. Another nurse who was partially at least, sort of responsible for this patient's demise was offered a promotion to the ICU. So many things happened in my career along the way where I did not feel like I had enough psychological safety, right? Which is that belief that I am safe to take risks, interpersonal risk taking, other types of risk taking. So psychological safety is a huge, huge factor, I want to say, for promoting civil behaviors in the nursing profession and making sure that we're creating environments where equity really is present and persons are not coming into work feeling like you will treat someone else, very differently than you treat me because of the perceptions that you may have about people of color and what you expect them to be able to do or not be able to do. And so while we're battling, burnout and all of these different things, nurses of color report much higher levels of burnout and emotional lack of safety than their white counterpart nurses. And so being mindful of how we create our environments, right? Just for everyone, how we create inclusive spaces, what I like to call coaching culture, or create places where persons can come in and they can feel like they can express themselves and they can, say things without fear of retaliation, I think is really, really significant. And I wanted to also point out, because I'm a huge advocate for coaching, and that really is just creating space for people to be motivated to do their best work. The Cleveland Clinic did a really, really excellent process on promoting coaching culture with their physicians, where they were actually able to help the health system avoid $84 million in physician turnover costs over the past decade. Wow. By allowing physicians to coach each other, right? And Dr. Johnson mentioned the resiliency, with physicians. I would say the same is true in nursing. I don't think we have been offered this opportunity in nursing, but what this example shows is that we can save money by, allowing peers to coach each other, to support each other. It also helped them with increased leadership. So there's a lot of value in really promoting a culture in organizations that says, yes, you do belong. We do believe in what you have to say. We want to hear what you offer. All of those things are really necessary and vital, I think, in contributing to the sense of safety and validation for people in our healthcare professions.
You both have talked about the tone, culture, the organization setup, and the environment it creates. And I think for the listeners, I would really highlight that of the ability of an organization to create an environment that is or is not conducive to healthy behaviors, healthy activities, healthy lives, including for its workforce. So I appreciate you both really highlighting that area. Maybe Dr. Johnson, coming back to you for a moment, are there differences that you've observed among the specialties even? Do we see burnout breaking down differently among the different specialties that are out there, or do you have any perspective on that?
Yes, we have data on that, and it's, I guess, consistent with what you would intuitively expect. So those specialties that practice on the front lines have higher rates of burnout. And indeed, over the past, since the pandemic, during the pandemic, I've seen disproportionate increases. So emergency room physicians, internal medicine, peds, OBGYN, family medicine, those people who are really on the front line have had higher reported rates of burnout. And these are also practices where people report a higher, lack of autonomy, which tends to drive higher levels of burnout. We see, in converse, we see that people who are in solo practices, office-based solo practices, tend to have less burnout reported in the surveys that have been done. And then in terms of what data exists on physicians of color, I would say there's limited data on. There's a definite need for more research in this area to understand the unique experiences of physicians of color. What exists, we have seen that, as we've heard from our nursing colleagues, not feeling valued at work contributes to physician burnout.
Right. Feeling
that you have low advancement compared to your peers, perceived racial or ethnic barriers to advancement, all of these things add to physician burnout. And so when we talk about institutional measures to try to mitigate what is a very expensive thing, I mean, replacing workforces, again, as has been said, costs a lot of time and also a lot of financial resources. It's much more efficient to keep your already trained force. And so making sure that you have an equitable system, that you have transparency in how it is people are hired, how people get promoted, how people are compensated. All of these things are very important so that everybody can feel that they're being treated in the same way to decrease the chances of burnout and people leaving the profession.
Well, maybe related to some of that, what about some of the tools that have been in place? You mentioned health record systems earlier, but I think of things like prior authorization and step therapy and other systems that are in place where seemingly the intent is to manage better or provide better care. Do those contribute in any way to some of the challenges that you're observing?
They do, and I would like to, congratulate those groups who have been instrumental in trying to get changes in some of these areas, such as prior authorization. Most recent changes that the plan is to have, at least for procedures, prior authorization done on a computer-based way rather than, a series of phone calls and phone tag, which is just very a time sink. The electronic medical record certainly has many advantages, but understanding that having a clinician spending more time on the computer than with on a face-to-face encounter with a patient might not be what it is we desire. Seeing how it is, perhaps AI and scribes can help decrease some of the burden that physicians feel from documentation and bureaucratic type of responsibilities would also be helpful.
Indeed. And, I think another big topic that's been out there, we talked a little bit about education and training at the beginning, but there was a recent, very significant Supreme Court case effectively eliminating affirmative action in higher education. Maybe, Nikki, I'd start with you and ask, what's your perspective on the potential impact of this case on building and growing a diverse workforce in healthcare? And then Dr. Johnson, I'd ask you the same.
Yeah, that's an excellent question. And it's interesting that you asked that because I'm actually going to be starting in, full-time academia. And I actually posed this same question to the National League for Nurses just to kind of get a sense of what do they think? Because, I'm kind of new to this process. And, the responses have really varied. I think part of the biggest challenge with this is that people don't know enough about what affirmative action, has really done it. And myself included, right? I'm not a politician. I don't, go looking for what that all means in each and every interaction. But what I can tell you is that with the academics, leaders that I have spoken with, they've mentioned something called the chilling effect. And I don't know if, that's a familiar term, but essentially the chilling effect is when persons don't really know what they can and cannot teach or how, they can talk about real life things like how race has impacted us historically. Right. When people don't know how to do that, it really makes it more difficult for them to want to teach those things. And then also, when you're really thinking about academics, it forces you to be really, really intentional, right? Around, okay, so maybe we cannot really consider race in terms of admissions, but what are the other factors that we can consider? And if you're, working at an institution where they're not wanting to take those types of things into consideration, it's going to pose a barrier, right? It's going to make it more difficult for persons who would like to, pursue school or pursue advanced, training to really feel like they can safely and comfortably do that. And it makes it more challenging for academic, leaders to think through what is it that we can and cannot do. So my belief is that this is going to be a challenge that we're all going to have to face. I know for nursing, we've been doing a lot of work around health equity and our standards, our AACN, our credentialing body, the way we're trying to standardize health equity. So I'm interested to see what ways in which, our credentialing body is going to really navigate this terrain. It's all really new. I know that for our standards, we've really been pushing health equity. So my hope is that there's going to be some guidance to all of our academic institutions as to what are some ways that we can navigate this new terrain, because I think a lot of people are going to not really know what the next step is. My hope is that we would continue to create open, honest dialogue with between our students, with our faculty, with our clinical partners, so that we're all thinking together, right? The worst thing I think we can do is get into these silo behaviors where we think we have to create these, these processes independently. We don't have to do that. We can collaborate one with another, and we can learn together so that we can truly support each other. But I do think this is going to be a challenge. I do think it's going to be significant, and I do think we're going to have to work together to get through it.
Thank you. And Dr. Johnson, your perspective.
So we have plenty of documentation in literature that diverse teams are more productive. They ask different clinical questions. They ask different research questions. And this is true in the medical arena. It's also true in the non-medical arena. And the affirmative action allowed us to have more diverse students at tertiary institutions or institutions of higher learning. So without question, this is going to make it more challenging to have diverse representation, not only in medicine, but across the board. And so the healthcare industry, as will other industries, are going to have to be creative about how it is they maintain or create diversity when they're not ensured that those people will be in institutions of higher learning.
Indeed.
There are discussions about looking at economic diversity as a way of making sure that we have representation from across the socioeconomic strata. There are discussions about looking at seeing, colleges will admit the top 10% from local schools as ways of trying to be sure that we reach all students, all talented students, recognizing that not everyone has the same opportunities if they're coming from schools that are not as well resourced, if they do not have an opportunity to have coaching, private coaches, SAT classes, and all the rest of it. So we have a heavy lift ahead of us, and it's not unique to healthcare. Certainly would be a challenge that we have to take on. And we can see in those states where affirmative action had been struck down before, the numbers of diverse medical students suffered.
Well, a heavy lift indeed. And I think that might be the right spot to wrap up this part of the discussion. And so I want to say thank you to both of you for sharing your perspectives, sharing your insights and stories, and helping us advance this conversation today.
Thanks for having me. Really
Thank you.
Appreciate it.
Thanks very much for the opportunity. It's really a timely discussion, and I'm sure everyone will appreciate the fact that you spent time on this topic.
Indeed. And folks, a very timely and very important discussion, certainly, and one I hope will continue a couple more times. That's been another episode of the Medical Alley podcast. If you're not already a subscriber, make sure you get over to medicalalleypodcast.org, or you can find us on Apple, Spotify, or wherever you go for your podcasts. And would you do me a favor? Would you share this episode with at least 2 other people? I know I normally ask for 1, but this is a really important topic. So share it with at least 2 other people. Help spread this story and this information so that more people will hear it and understand. If you do that, I'd really appreciate it. Until next time, have a great day.
Thank you for listening to Heart Nurses. We invite you to visit pcna.net for clinical resources, continuing education, and much more.